Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors, Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are in Crown Point, Indiana. Is that right, Bob?
Yes, sir.
Yeah. So we are sitting down one of our favorite people on planet Earth, Dr. Babb Newhaven. So, Bob, we appreciate you, number one, bringing us down for the DNS baseball course, and then also for setting up this amazing podcast. And so today we're sitting down with Dr. Andy Babb. And so Dr. Babb has really influenced your life heavily, Bob, in the way of reconstructing your airway through dentistry, through tongue ties and things like that. And so we're very interested in this, number one, because it's a question we get all the time, number one, but it's hard to kind of sift through, I'm going to say, the bullshit of what this actually means. And so can you maybe just start off, Bob, with kind of like your journey and kind of what led you to Dr. Babb, and then we can kind of get more into the details.
Yeah, heck yeah. Well, first of all, thanks for coming. Thanks for making the trek out to the burbs.
Oh, yeah.
And Dr. Annie, thanks for agreeing to do the podcast too.
Yeah.
Because I think it's going to be awesome. So I have two kids myself. My daughter's 9. My son is 6. So our story is my wife had some trouble breastfeeding. And I was just at a loss. I couldn't help her. I was like, I have literally no idea how to help you. And, I, like you gents, that kept me up at night. I was like, all right. So I started, sifting through and reading things. And I kept coming back to this idea of oral ties and tongue ties and lip ties. And, this is a couple years later, I reached out to a local myofunctional therapist in this area, Stacy Lashenick. And I was just like, hey, I don't know if this is my daughter or whatever, but can we have coffee and you can teach me and talk to me about some things? And, even just during my eval, she was like, oh yeah, well, let's look inside your mouth. And, my mouth was a hot mess. I had a very narrow vaulted palate. I had a pretty thick lip tie, and, I had what they categorized later as a class 4 tongue tie posterior that, when I was a kid, they just weren't looking at those things. And even still now, they're not looking. I don't think a lot of professionals aren't looking at them as much as they should. And so that started me down the journey of, okay, well, let's look in my kid's mouth. And my daughter had a pretty thick lip tie, and she was starting to develop the gap between her teeth. And so I got hooked up with Stacy, who then later on hooked me up with Dr. Babb, because I was like, you know what, if I'm going to put my kids through this, I want to go through this myself. I had already had braces twice, and I ended up getting braces a third time because my palate was so narrow, my upper teeth, that my tongue didn't have room. There's no room for it. And so I was a mouth breather. I had my tonsils out. I didn't sleep real well. So my big story was I started tracking my sleep. And the first time I tracked it, I was like, no way, I'm awake for 30 to 45 minutes a night. So then I bought a second tracker, and I put 2 trackers. And at one time I had three sleep trackers on my body.
What a psycho.
I was like, all of them said the same thing. I was like, all right, well, there probably is a little something here, because I was like, oh, it's just my kids. And I'm like, yeah, no, definitely a
Couldn't
sleep
be me.
problem. No, yeah, definitely a sleep problem there. And so, I ended up getting evaluated by Dr. Annie, who, I ended up needing adult expansion just to create a little bit more space. I did ortho, and then I did some myofunctional therapy before my tongue was released, because one of the big eye openers for me was when they had me put my tongue up, I couldn't swallow with my tongue up. And they're like, well, that's where your tongue's supposed to be when it's up. But it was so thick and tied down that I had no idea how to use my tongue. And so, again, and that's what led me to Dr. Annie. So I went through all this stuff, and now my sleep is way, way better. And it's still a journey for me, but it's pretty rare for me on any given night to be awake for more than 10 minutes. And my deep sleep went from 30 minutes a night to, my worst nights now are 40, but I'll get an hour plus of deep sleep pretty regularly now. So I've doubled my deep sleep time. And that was all through like this work.
Sure.
And so, it's been, life-changing for me, but also, my daughter, she's going through the process right now. And I can say, hey, I've been through this too for her, and so I'm one of those people, like I try to walk the walk to the best of my ability. And so my daughter saw me going through it. So now she's trucking through, and my son is he's a mouth breather. So I got to him a little too late. So he's going to have to go through the same process as well, or he's going to run the risk of having some of the same issues that I have.
Beautiful.
So, and that's how I got hooked up with Dr. Annie.
Well, that's amazing. So Annie, can we just maybe start from the beginning? Like, maybe start on the assessment piece. I think that's a big thing that I'm really curious about myself.
Before we do that, what do you think is this a genetic thing? Is this what is the cause of this? I mean, in Paleolithic times, were we having more or less of these? Like, as time has evolved, like how does someone even get to that point, do you think?
Yeah, so there's a lot of, they don't know 100%. I kind of always explain it to patients that it's genetic and that you have a predisposition to have restrictions. And they think it's genetically dominant, so it makes sense that we're seeing more of it. There's a lot of different factors they've talked about. Like, there's arguments over whether the frenum is a midline structure. I would say that it is, because if you look at development, it's a midline structure during development, and then it should dissolve. And so if it doesn't, what's caught up in there, and then how much is that restricting movement? Why is it not dissolving? There's some that say it could be because of folic acid, because women take folic acid to prevent spina bifida. So not that you would stop taking folic acid, we need it for this other reason. But that's a thought.
When should it be dissolved by?
I don't know that. I don't know at which stage of development. I have some of like my own kind of theories on it, because I think it has to have something to do with space in utero. Because if you think about just how the body moves, if it doesn't have a lot of space to stretch, and then everything is kind of forced together, and then the tongue doesn't have room to move either. So it's kind of like what came first, the chicken or the egg. And I feel like it's just so deeply related to everything else in the body that I don't know. It's hard to say. And that's pretty much what I tell patients. Like, we don't know. Yes, we're seeing a lot of them, but also this has been around, I think, since Caesar, the instrument that I use to hold up the tongue, they have pictures of from back then.
Yeah. Oh, that's cool.
So I think it was more commonplace to just release at birth. And then somewhere along the lines, we got away from that. Women stopped breastfeeding as much, and now breastfeeding is back on the rise. And so I think we're realizing that it's a problem more. Plus, there's social media, and women have a network where they can talk to other women. And, there's also a lot more women in medicine now, too. And for me, that's kind of how I got into it, was for myself and my daughter. But when you go through breastfeeding a child and it's really challenging, you're going to be like trying to figure out why, you know? So.
Well, and I think maybe, Bob, you started to talk. I think when we look at development, we're all DNS, purists or whatever you want to call it. So a lot of times need is what kind of pushes development. And so do you think that because maybe we've gone through these stages of less breastfeeding and less longer periods of time breastfeeding, that maybe has changed the shape of the palate genetically? Do you think that the need for food and breastfeeding has an effect on the palate, and then in turn the actual frenulums?
I think it probably has more to do with like our dysfunctional breathing, mom's dysfunctional breathing. They've done studies on like Sherpas, pregnant Sherpas, I think, and the changes that happen when mom doesn't get a lot of oxygen and what happens to the baby in utero. And there's all kinds of things related to mom's ability to properly breathe and baby's development. So I think probably more to do with that. And then when you get into palate shape, that is affected a lot by the cranial bones and how much space, the skull has to expand, and is the skull expanding the way that it should. And when a baby goes through the birth canal, there's a signal to the body to then move the cranial bones back. So C-section babies tend to have less of that movement because they miss the signal. They don't go through the birth canal. The body doesn't get that signal. So if the cranial bones don't expand to where they should, the palate is inside there. And so if those sutures are tight or the bones are not where they're supposed to be, that impacts the palate, and tongue position impacts the palate. Food impacts the palate. If you're not eating hard foods and growing the jaw, form follows function. So if you're not challenging the jaws to do, the muscles, then the bone doesn't develop as well as it should either.
If we had 100 babies here locally, or 100 children, and we lined them all up, how many, like if you assess them, what is the percent, how would it break down?
Yeah, that's hard for me to answer because I'm in an orthodontic office.
You see a skewed bunch,
yes.
Yeah.
So, pretty much, like I always say, you're in an ortho office for a reason, and it has something to do with your tongue.
Right.
So, whether the tongue is low because of habit, or just, prolonged pacifier use, thumb sucking, whatever it may be, or if it's actually structural, the tongue has a lot to do with teeth position. So, I see a very skewed population. I think
More than 50? Do you think?
Oh, in what I see?
Yeah.
Yes, more than 50.
Yeah.
In the general population, I think it's supposed to be like, they say maybe 5 to 10%. Don't quote me on that, but it's not that many. But then what I see is a lot.
Right.
So it's kind of hard because sometimes I think like, man, is this, am I just making this, like, am I overdiagnosing? But I don't believe that I am. I actually think I'm pretty conservative. But again, they're in our office for a reason. So there's going to be more tongue ties in that situation.
Well, I think it makes sense too from a DNS perspective, because we talk about like the kids with cerebral palsy, they have what we call a Gothic palate because the tongue doesn't have any lateral movement and rotational movement, and the tongue is. And then later on, we talk about the importance of tongue function and athletic function and things like that. So if there's any limitation in the tongue, I think it makes perfect sense on how this is all related.
Yeah, for sure. I think that I've recently been talking about, like, if your legs were tied, if we saw a child and their legs were connected at the ankles, they wouldn't be able to walk, right? And so you would say, like, that's severe. We need to do something. And if they were attached, like webbed to the knee, they could kind of waddle, but you would see the body compensations of that, right? That's pretty evident. You'd see like the shoulder, it would just, the whole body would be involved. And then if they were webbed closer to like the upper thigh, they're still going to have limitations in how they move. And we would see that. Like, that would be easy to see. But for some reason, we don't pay attention to that with the tongue, and we just ignore it. And it's like, well, if you can talk, if you're eating kind of, like, because I say kind of because so many of these kids have so many, like, they have aversions. They only want soft food. They want chicken nuggets. They don't chew meat. They don't like to eat meat. That's a really common thing we'll ask is like, are there aversions? It's always meat. Always, because it's a lot of work to chew meat. Right. And so, like, why is that not okay? Or why is that okay? I guess I should say. We just ignore that. Maybe because we don't see it, but the tongue is involved in so much. Like, it's the start of digestion. It's how majorly important in breathing, speaking.
And then how do you know, like, where to prioritize, like, let's just say occlusion versus, everything we're talking about now? Is that something you're sorting through, or they work together always, or?
Pretty much, if the tongue is up in the roof of the mouth when you're growing and developing, and the forces of the face are balanced. So I always explain that the teeth sit in an envelope between the tongue and the lips and cheeks, okay? If the tongue's up and the lips, you don't have like these odd movements because of a restriction where you have a compensatory, tension or movement a different way. The teeth would be this nice, beautiful, wide arch. Your occlusion would be good. Like, it just takes care of itself.
Right, yeah.
They didn't have orthodontists in prehistoric times. And you look at those skulls, and that is beautiful dental occlusion. So it's really, again, form follows function. If the tongue and the muscles are doing what they're supposed to do, everything else kind of falls in place.
Perfect.
And breathing, like our breathing as a society is not good either.
Right.
So that's, yeah.
Yeah, I love it. So then maybe can we I'm glad you interrupted me there. That was good. Start on the assessment. So what are you actually looking for? I know we kind of got into a little bit aversions to eating, maybe difficulty with food, things like that. But then as far as like hands-on, what are some of the things that you're finding maybe functionally I'm purposely asking this question to teach our listeners and myself what we should be looking for when it comes to things like that.
Yeah.
Maybe not specifically from your perspective, but maybe outside of it, musculoskeletally.
Yep. Well, there's a whole kind of slew of symptoms you could look at if you're just looking at a child or an adult from like point blank, like not really assessing their body necessarily, but just things like sleep disordered breathing. So non-restorative sleep, bedwetting is a big thing. ADHD oftentimes because they're not getting good sleep. And so then like you have to be in deep sleep to have emotional regulation and all those things. Poor growth sometimes because they're not getting into deep sleep to release growth hormone. There's a bazillion of those things that I could go into, but if you're actually looking at the body, a lot of times, like from your perspective, you would see some postural things typically. So often rolled shoulders, forward head posture, pretty much always, I would say. What else would be?
Narrow face.
Mm-hmm. Narrow face. Yep. Darkness under the eyes because the maxilla, the upper jaw, hasn't grown as far forward as it should. So there's not support under the orbit. So blood will pool there.
What about more clenching? Is there more clenching and bruxing? Yeah.
Yeah. So there's pretty much two phenotypes. Okay. You either have the mouth breather, which is going to be the long, narrow face. And that's usually when you'll see like the darkness under the eyes. Sometimes like drooping of the corner of the eyes will kind of droop again, because there's just not the bone support there. That's like the kind of the classic adenoid face. I'm sure you have heard that before. Like if you see a kid who has enlarged tonsils, that look, that's a mouth breather, usually underdeveloped, mandible, lower jaw. So you kind of have like a moon. Well, you can have a reverse moon too, but usually just kind of deficient. Mm-hmm. Or you have the clenchers. So clenchers, if you look at them, if you look at their face, you're like, they actually have pretty decent facial development. They have a strong jawline. They have, they're not super long. They're actually more usually shorter because they're clenching. I find that those, when they are clenchers, they tend to be more restricted. Because they the way that the tongue can't move, the only way they can function is if they clench. And so that's what they do. Mm-hmm. And so you wouldn't necessarily look at them and think like, oh, they've got airway issues, because they have a pretty broad palate because they're always just clenching. So the tongue is kind of up there, but not really. It's up there because they're clenched. And so there's nowhere else for it to go.
Sure. What about Bob, from your perspective? You've been referring patients back and forth. What are, besides the things that she already talked about, what are some of the cues? Like, obviously they're probably not responding to treatment in a certain way, but like, what's the profile of patient that you love to send to her?
Sure. Yeah. So as far as kids are concerned, definitely if there's any kind of developmental delay, especially with prone positioning. So a lot of those kids, if they're too fascially tied in the front, they're going to even them move their head forward and up, and they're not going to be able to support themselves well. So any kind of prone delay, that's a pretty classic one. Or I'm seeing in even infants, really recessed jaws. Kids, when they're swallowing because of the restriction, they'll literally pull their mandible back. And they'll
in an attempt to make more room.
In an attempt to swallow, and they'll actually choke on their saliva and spit everything up. So as far as like infants, and then kids, kind of all the things she talked about. But as we get older and adults, I'll actually see very small nostril holes, or I'll see an asymmetrical. Forward head posture is one. Just kind of, I think a lot of the things that she talked about, but it's gotten to the point in my practice where I'm always assessing it. Mm-hmm. And then it's, is it something that, I want to address or not? Mm-hmm. Or is it a secondary or tertiary issue, or is it a non-issue at all? So once you get especially good enough at the assessment, it only takes a couple minutes for the way that I work it into my practice.
Do you want to go through your assessment, kind of just give a little bit of a highlight, like what you're looking for on your new patients and things like that?
Oh yeah, sure. So when they come in, I'm just looking at their facial features, and so that's from training from Dr. Annie. Is just I'm looking, are they long and narrow? Do they have any facial asymmetries? Do they have any excessive like SCM tone or accessory respiratory tone? Do they have forward head posture and rounded? So and I think for me, really forward head posture. So not a little bit, a little bit fine, but we've all seen like the CT junction significant kyphosis. For me, I'm looking in the mouth like every single time. So these people come in with cervical disc or kind of constant repetitive cervical things, headaches, like I'm looking in the mouth. And then what I'll do is I'll look at their nose, look at their nostril size. I'm visually inspecting to see if I see a deviated septum. You would be surprised if you start looking how many times you can see a deviated septum just visually. It's crazy. And then I'll do. And
then does that immediate referral to an ENT for?
I will immediately refer them first. So they have a scan where ICAT scan where they can actually get an image of the septum too to see how bad it is and structurally how much it matters. Right? If it's a little one, For us, I would probably start with orthodontics first, depending on how dysfunctional the breathing is. If it's severe, then I'm sending it to an ENT pretty quick.
Nice. Keep going. You're doing great.
Yeah. And then, depending on what that looks like, then I'll go in the mouth. And so I'll look just for any kind of lip and buccal ties, and then I will start to assess tongue function, tongue to spot, tongue suction. I'll do a floor of the mouth hold, and then one of the big ones that really I think is eye-opening for people is if I am suspecting any kind of tongue tie or tongue restriction, I will do a floor of the mouth hold, and I'll see if they can lift their tongue as I hold their floor of the mouth up. Me as a class 4, I couldn't move my tongue at all when they held it up. And then I will have people put the tip of their tongue to their incisive papilla, which is called tongue to spot, and I'll have people swallow. And I will video people swallowing, and you'll see people jut their head forward. You'll see people jut their head back. You'll see people retract their jaw. And so, or they'll use their mentalis, their facial muscles a lot. And so that's, I think, really eye-opening for people when I'm like, listen, you can't differentiate your tongue from your other swallowing muscles. This is a problem for you. And I would say, and then, the standard DNS breathing assessment too. If I see any kind of like significant breathing dysfunction, that's also another thing that will lead me to look in the mouth.
And I think everybody that's listening is going to want to know like exactly what are we looking for with the tongue? Like we've been saying tongue tie, but like exactly what exactly it is that we're looking for when we're.
Sure,
this could be for Annie too.
I would let Dr. Annie answer that.
So I can actually send you guys some of the pictures that I include in or he's got them too. I
have 2 folders for you guys.
Yeah.
Oh, nice.
So you can include. I don't know if you can include it in the podcast or not, but so there's actually there's all these different grading scales for the tongues, so it can be a little bit confusing. The Carrillos scale is what I use in babies, and so it's a grade 4 in a baby is actually a posterior. We're trying to move away from posterior because it's confusing to people. It's really mid-tongue, ability to lift the mid-tongue. So you can't really see a Carrillos grade 4 in a baby unless you know how to properly assess. So you have to elevate, basically come like from behind, and you kind of have to like lift the tongue. And then 1 is tied to the tip in a baby. In an adult, I use a functional scale, and it's the opposite of that. So a grade 1 in an adult or an older child, is basically full function, full mobility, no tension. Okay. A grade 4 is tied to the tip. So it's flip-flopped. It's very confusing. But what you're looking for is not just the presence of a frenum. We all have frenums. You have to have attachment. Like your lip has to be attached, your tongue has to be attached, but it's about how much restriction is in that frenum. So yes, if you see it, okay, but it's more about how it feels. Sometimes you'll see the floor, you can actually see the floor of mouth lift. So if you lift if you have them lift their tongue, you'll see the salivary ducts kind of alongside, like caught in the middle of the frenum. And sometimes it'll look like an Eiffel Tower. So you'll see webbing below that when they elevate the tongue. So you'll see this web at the bottom, and then the salivary ducts, and then the frenum. Okay, so it looks like the Eiffel Tower. But it's more so about how it feels and more so really about how it functions. Like I'm always telling my patients, if you have a little bit of tension, but it's not impacting you, there's nothing for me to do.
Right.
And I can't tell you exactly how much it's impacting you. Like you're in my chair for a reason. So what are those reasons? And especially in adults, I'm going to be really more conservative because we're past growth and development. Like I'm not here to tell you we have to do a surgery if you don't want to do it, but how's your sleep? How's your breathing? How's all these things? Like he said, the biggest and easiest way I think for most people to quickly assess is to put a finger in the floor of the mouth and have them elevate the tongue. So I usually will ask them to open as wide as comfortable first and lift the tongue. And I just want to see what it looks like, how it's moving. And then I'll put a finger in the floor of the mouth and have them do the same thing. And you'd be pretty surprised at how different that can be. But again, if there's tension there, but there's no symptoms, you don't do anything. And then another way is, so he was talking about having the whole tongue up in the roof of the mouth. You can also assess that way. So if you have them do what's called a palatal suction, so the whole tongue resting up in the roof of the mouth, and then you push down in the floor of the mouth. If the tongue drops down, they have more of like a mid-tongue, posterior tongue restriction. So it's how it feels and what it's doing to the patient.
And what about like lateral tongue movement? Is that not so important for you guys? Or?
Yeah, no, it is. So when I see patients, so when I do releases on the older kids, or I don't do adults very often, but in the older kids, it's a functional release because they go through myofunctional therapy before and after. So the myofunctional therapist will assess for compensatory muscle movements, like he was talking about moving the jaw forward, moving the jaw back, having the mentalis activated, or any facial muscles. So if you see those kinds of things, jaw moving side to side with the tongue moving side to side, tells us that the tongue is not moving independently. So yes, you're looking at that. Neck engagement is a big one. So you'll have them elevate the tongue and you see the whole neck kind of light up because all those muscles are working to elevate the tongue. And that shouldn't be the case.
We see that like in our T&D cases with mouth opening, like when they go to open their mouth, just like we'll say 45 millimeters, like you'll just see all this activation everywhere,
Yeah. And those, a lot of patients who have TMJ issues, I'm not going to say every patient, well, they probably all have a degree of tongue dysfunction, whether it's because of a tie or not, that's what you have to figure out. And that's also why we do myofunctional therapy. Like I always explain, first, you have to make room for the tongue, okay? Because if you don't have room for the tongue, you're going to have all the same symptoms. If the tongue can't get to the roof of the mouth because there's no space for it, you're going to have the same symptoms you'd have if the tongue was tied. Right. So you have to get the palate wide enough for the tongue first, and then teach the tongue to go up there and see if we're getting symptom improvements. Are they able to do those exercises without compensation? And if they're not, and symptoms are persisting, then you do a release. Then you address the structure.
And how about on the lips? Were we looking for lip tie?
Yeah, lips are a little bit more obvious, I think. You just kind of elevate, like for the upper lip, you would elevate it over the nostrils, and then again, see where the frenum is. If it's located kind of in between the papilla of the front teeth, then that's a low attachment. You can kind of push like up on it, and you'll see blanching. The tissue will turn white. Sometimes that whole papilla will move. That's how you could tell with that. Yeah. Gummy smiles are often related also to, it's downward growth as opposed to forward growth. That's going to contribute. So vertical growth will contribute to gummy smiles, but a lot of times there's a lip tie involved there too. So because when they smile, the lip kind of curls up with the smile. And so when you release it, it's almost like getting a lip filler.
Yeah.
Is there any downside to, like, I guess if you're playing devil's advocate, you could say, well, do you ever like impart too much motion in these structures now that we've like untethered it, or that's just not even a concern or anything like that?
You mean like if they're free to move, could that
now
cause...
you've given them all this new motion. Is there any downside to that ever?
There could be if they don't have room. If they don't have enough room and you've freed it up, Like, why'd you do it? Because now there's nowhere for the tongue to go. So that can cause some issues. And if you do a tongue release without, and this is my prerogative, I'm sure people would argue with this, but if you do a tongue release without therapy, without teaching that tongue where to go, you're doing a disservice to the patient, because you've got this freedom of movement, but they haven't changed underlying issues, and that's not good. Like, they've functioned for this long with the tongue this way. If you're not addressing what to do once they can move it differently, then you can have some struggles with different things.
And is the rehab, this is for both of you probably, just exercising the tongue, or is there also a soft tissue component with the structures around the tongue, or a combo of both?
It's a combo of both.
Yeah.
Because myofunctional therapy addresses the tongue, but then also the facial muscles and the neck muscles and all those things. So that's really post-op what you would do. I would also love if my patients would all do some form of body work before and after. The babies, when I do the babies, most of those parents are really pretty good about it. But not all body work is created equal, and different babies need different things. And I'm still learning a lot about that. That's something we talk about too, is like how to know when to send to who. But yes, I would say the babies, they have more like full body rehabilitation pre and post. Older kids would benefit from it, but they're also going through so much. Like, they're in ortho, it's a lot. It's a lot on the parents, and it's a lot on the patients to do it this way. So
what if we see like parafunctional habits like tongue thrusting and stuff like that? And is that the cause, or the what's what?
A lot of times if there's a tongue thrust, there's a tongue tie.
Right.
Not always. I would say probably the majority of the time. But sometimes that's, again, prolonged pacifier use. Also, bottle feeding is different than breastfeeding. And I'm not one to, like, some people cannot breastfeed. That's not an option for them. And that's okay. But there is a difference between bottle feeding and breastfeeding. And bottle feeding encourages a little bit more of that dysfunction because of just the dynamics of it.
Mm-hmm. And in your world, how long do you like the children to be breastfed if everything is working properly?
I mean, I think it's up to the mom, whatever the mom feels comfortable doing, but longer is better. I mean, that's what helps shape the child's jaws, really. But as I explained to the baby moms, just because your child's breastfeeding and gaining weight, that doesn't mean that they're breastfeeding well. Mm-hmm. And especially moms who've had multiple children, they don't always notice the dysfunction because they're used to it, you know? And so they'll say, like, there's really no symptoms. And then I'll watch the mom breastfeed. And I'm not a lactation consultant, so I'm careful to, like, not give too much input. But I'm like, well, you know, I see your baby's jaw moving up and down, and I see a shallow latch, and I see all these things. That's not going to shape that child's jaw properly. A lot of times, the issue with breastfeeding is they can't elevate the mid-posterior tongue. So when at the breast, they should be able to have a wide latch, and then the mid-tongue should elevate, and it creates a vacuum. And that's what pulls the milk out. If they can't elevate the mid-tongue, they basically use the mom as a straw, and they'll suck. And sometimes they actually clamp the nipple off, and then you have an issue with mom's not making enough milk because the body's not getting the signal to keep producing milk, okay? So with that sucking force, you're getting narrowing. Mm-hmm. So just because the baby's breastfeeding, if they're not breastfeeding right, they're having all these narrowing forces.
And is your assessment so bulletproof to where you could almost assess the babies and know whether or not they're able to breastfeed well? Like, is it that correlated?
I would say pretty, yeah.
Wow, that's amazing.
Yeah. But like, you'll have moms who have a really strong or an oversupply, basically, or a strong letdown. And they'll say, like, my baby's feeding fine. I don't have pain. I'm like, well, what's your supply like? Mm-hmm. What's this look like? Because if you have an oversupply or a strong letdown, your baby's not working. Mm-hmm. They're basically drinking from like a hose, you know? So it's like, yeah, they're going to gain weight and you're not going to have a lot of pain, but they're not having to do the functional movement to actually pull the milk out. It's just a mismatch of, you know, of the breastfeeding diet.
Right.
Really.
Right.
Beautiful. And then how many of these patients are, what percentage are requiring orthodontics? What percentage is pure just in your chair? Because we talked about basically every single person realistically needs a therapy that's involved with that. But what about the split between the orthodontics and you?
Yeah, I mean, pretty much they all need ortho too. In an ideal situation, because you have to make room for the tongue. The tongue wasn't up there when they were developing. So in order to kind of get them to their genetic best, they need ortho.
And does that always require palate expansion or not necessarily?
Pretty much always. I mean, in my opinion, yes. Can you do it without palate expansion? Maybe sometimes, maybe in a clencher, where the tongue has kind of put a lot of pressure there. But really, we've been finding in the ortho side of the practice, pretty much we're treatment planning expansion and protraction. So getting that upper jaw forward, so making it wider and getting it forward, they need that. Because what happens is the maxilla as a whole is underdeveloped. And so it'll lock the lower jaw back then too. And so then you get that retruded mandible and it's locked in there. They usually have a deep bite and the mandible can't come forward because it's hitting this maxilla. And so a lot of times the mandible gets blamed. Like if you have a class 3, which means the mandible's forward, that is another thing that can happen where you get kind of like that bulldog shape face. And historically, orthodontists would give headgear to retrude the mandible back. And what do you think that's doing for your airway? Nothing good. So it's actually the maxilla that's the problem. The maxilla is underdeveloped because the force of the tongue pushed the mandible forward instead of the maxilla forward. So you actually have to get the maxilla to catch up.
I would say really quick too, because she mentioned it, one of the things that they do at their practice is they actually measure the airway with the iCat scan. So they get in there and you can actually measure it and look at it too. And that's one of the ways that they help determine their orthodontic plan. And I think that's a really important thing for listeners to hear, is that like they're measuring the upper airway to see how much space is there. What do we actually need to do to open up the airway space? So it's not just about the teeth. Right. It's about the whole shape of the face and the airway.
Yeah.
And what are the ways to expand the palate? Like what are the...
Yeah. So there's some different palatal expansion devices. There's light wire force, which would be like a W arch would be what that would be called. You can sometimes expand a little bit with just brackets, depending on the type of bracket system you use. You're not going to get a ton of expansion from that, but you can get a little bit. There's also, they've historically been called rapid palatal expanders, and they're cemented in basically, and then it's the traditional like you turn it. Yes. But we don't turn it fast. Yeah. So that's pretty much what the orthodontist I work with uses, because it just works well in her hands and she feels like she has good control over it. And so we turn it, the upper, usually twice a week, as opposed to I don't know what they used to do every day. I'm honestly not sure. But it's still a slow expansion. So slow is better. I'm sure you guys can understand why. Like you have to give the body time to catch up to what's happening. So there's a few different devices, and I think it's important to know it's not so much about the device. There's also removable expanders too. So it's not so much about the device; it's about the person who's prescribing the device and what works well for them.
And how long do they usually wear the device?
It varies. I would say about 6 months, but sometimes it's a lot longer, and sometimes they're in there for longer and we're not actively turning it anymore. It's just maintaining the space.
Sure.
So like you had a W arch, right?
Yeah.
I think you did.
Yeah.
And that's what I had. Those are in there for a lot longer. They're slower. And they don't really inhibit like tongue position quite as much with the rapid palatal expanders. Which I don't like calling that because we're not using it that way, but they're pretty bulky. And so then that kind of inhibits the tongue from being where it's supposed to be. It's kind of a necessary evil. Like we need the palate to expand, but then we want to get that out of there relatively quickly so they can learn to get their tongue up there and hold the space. Yeah. So
beautiful.
And, go ahead.
No, you go.
And you're in the training world. So like, what do you think, what implications does this have for athletic function and things like that?
Oh, I think a lot, So the further I'm getting into this, in DNS, we talk a lot about the lower portion of breathing, and we don't talk a lot about the upper airway. And the more I'm seeing is like, if your tongue can't function right and you're closing down your upper airway, you will very often compensate posturally somewhere. And as soon as you do that, now you're on a limited window for performance and training. Right.
So what are the mechanics of everything that we're talking about and how it's actually closing the airway? Like what's the mechanism?
So that would be more, yeah.
So if the jaws don't grow, as far forward as they should, which again, you can give them my slides because I have some images on there. So if you think the airway portion that I'm talking about is the pharyngeal airway. Okay. So basically from like behind the soft palate to the epiglottis. Okay. That area. If your maxilla and mandible don't grow forward, that area is going to be pretty small. And not always, but often too small because you didn't get the forward development. So then the airway narrows. So there's just structural narrowing because things didn't grow the way that they should. But tongue posture also impacts the airway. So if the tongue is sitting low, it's more likely to occlude the airway during sleep because it should be up in a suction, and then the suction keeps the tongue out of the airway, but it also, the muscles that are connected in there also open the airway too. So when you elevate the posterior tongue or the mid tongue, that also activates these muscles that open the airway. So in terms of sleep, it's tongue posture, but it can be tongue posture with athletic performance too. I think you guys probably know the tongue is a big part of your postural stability. So if the tongue isn't up, you're not going to have that same postural stability. You're going to have different muscle compensations. Nasal breathing, just in general, also helps dilate blood vessels, and you're going to have better oxygen flow to tissues and things. And then with the diaphragm, specifically with tongue ties, with the fascia, there's, I hope I'm not going too far off topic here, but the deep front line of fascia runs from the tongue all the way to the toes. So it's tongue through the diaphragm, pelvic floor, quads, behind the knee, calves, plantar fascia. So with that, if the tongue is restricted, that fascial pull, it's kind of like wearing a coat that's too small. And so that pulls those shoulders forward, but it also does some things to the way the diaphragm can move. And it's different in every patient. It's not always, but I will ask during the procedure, like, how are you feeling? How does your body feel? Because I want them checking in. But after, I always ask the kids, how are you? What's different? I don't want to give them too many things I don't want to prime them for what to say. So I'll, see what they say. And then I'll say, how's your breathing? Does anything feel different with your breathing? And a lot of times they'll say, yeah, it's easier. I'm like, okay, where? Like, where do you notice it? And sometimes they'll tell me up here, but sometimes they'll tell me here. And so that to me tells me it's the fascial pull on the diaphragm. It kind of restricts, I think, how much the diaphragm can move because that fascia all in there is tight.
Yeah.
What would be the overall advice to the general public? I mean, forever we've taught the rest position of the jaw being lips together, teeth apart, tongue on the roof of the mouth. Yep. So has that changed now, or is that still good advice?
That's still good advice.
Okay.
Yeah. The tongue should always be up and the lips should always be closed. And we've talked about even training, for performance training, trying to run longer distances, keeping the mouth closed. And you can do that to a certain point, but once your heart rate gets to a certain level, you kind of can't
open your damn mouth.
You kind of can't do that. But if you when you watch the Olympics, if you watch the best runners, the best sprinters, their mouth is closed the entire time. Yep. They are nasal breathing the entire time. And so from a performance standpoint, that's huge. Definitely. And they do a lot of breathing training, I think.
Yeah, and I think that's one of the things that I see, if we're doing good DNS, good diaphragm work, and somebody's coming in and they're saying, hey, at mile 5, things start to get funky. I'm then going back and I'm assessing, okay, is it a capacity issue with them being able to keep their tongue up, breathe through their nose, and then they're starting to compensate posturally at some point, and now they're having back pain halfway into their run, right? And so okay, I can, that's where I'm starting to tie in globally the tongue function and the nasal breathing. And so figuring out, is it just is it a CO2 tolerance issue from, is it a biochemical issue with breathing, or is it just a capacity issue with, tongue to diaphragm connection that they just start to fade off slowly but surely and then change their posture because of it?
And phonation and things like that, I'm assuming you're telling me it's also related, like voice quality.
Oh, yeah.
Yeah. All that.
Let me make a quick comment about the CO2 and then I'll come back to that. So CO2 tolerance is huge because there's actually there's a body, there's a systemic regulation of that. And so there's been this big trend to lip tape And you have to be very careful with that because you can't go from being a mouth breather all the time to all of a sudden nasal breathing. Like it doesn't work like that. Like your body's been adapting and there's different things that are secreted to balance the CO2 and like you need to build up to that. So don't start mouth taping at night. You also have to make sure that you have nasal patency to do that. So that's like just a side
I can speak
note.
on my own. I started out of the blue and would wake up panicking in the middle of the night. And so it took me a long time. Yeah, it took me a long time during the day to adapt to nasal breathing, and then now at night it's much easier. But yeah, that 100% happened.
It's got to be a slow build. And so like in Myo, typically we'll do 5-minute increments where we build up over the course of weeks. We add 5 minutes. So just a PSA. Yeah, nice. Okay, repeat that about the
phonation,
quality of voice,
singing.
Yes. Oh, yes. Yeah. That related to the diaphragm, how much air you can hold in, how long you can hold notes, those kinds of things. Tone of voice too with adenoids is big. If you're a mouth breather, more so in kids. Adults usually don't have enlarged adenoids, but kids, because it gets smaller over time. Kids who have large adenoids will have pretty nasally voices. And so that can change as the inflammation decreases in those. Same with tonsils, you kind of have that like garbly sound. So as you decrease inflammation, it will change because of that, but also just range of motion for the tongue. A lot of the kids, I guess not a lot, but I've had many that have been mumblers. That's been a big thing. Like the parents are like, I just can't understand. Like they just mumble all the time. Well, they can't move their tongue, so they can't open their mouth that wide to project their voice. And so after releases, the parents will say, like, they're not mumbling so much anymore. I'm like, well, yeah, because they can now open their mouth and make the same sounds, Right. So yeah, a lot to do with voice. People who play musical instruments too, you'll see differences.
I would say real quick too is, not everyone is trained to assess tongue function that does phonation work. So I had a patient who brought her daughter in who was 6 who couldn't talk, who had been to, I think, 6 speech therapists. And she had a very significant oral tongue tie. And once it was released, within 3 weeks, she was talking. And so, I don't ever try to take things for granted that just because they've been through certain techniques and been to certain places that's been assessed, because I have, experience saying like, okay, this girl had a phonation, couldn't talk, and they were trying to make her talk, but she was tied down. So she just couldn't ever.
Too much effort.
Yeah, it was too much effort. But, she had the mental capacity to do it. She wasn't autistic. She wasn't anything like that. And then once they released the tongue tie, she was a completely different.
Yeah.
So I would just say for people out there too is, just because they've been to other professionals, like, still do your assessment. Yeah. Still do your assessment.
We always joke the same with MDT. Just because somebody has low back pain, they've been everywhere else, doesn't mean that it's not a derangement. So
yeah. And it's true from like a lot of people will say like, well, my pediatrician said it's not a problem. No knock on pediatricians, but they're looking at a lot of things. They have a lot of responsibilities with the body. The mouth is my responsibility. And if the pediatricians aren't trained in what to look for, I think I didn't learn this really in dental school. This was all my own learning after dental school. And so I doubt that they've had a lot of training in it either. And so, you can't always take that for everything, because they typically are looking at it in terms of speech. In infants, they're looking at, are they gaining weight? That's pretty much the main things. And there's so much more that goes into it, and there's so much more that it can affect. And so if you don't know, and there are, I would say most dentists don't know really how to look for it. Like you have to do specialty training to know how to properly assess. And so there's a lot of like supporting parents through being told there was nothing wrong. And then I tell them, well, this is an issue. And they're like, why did no one tell me that? And it's not any provider's fault necessarily. It's just we don't know what we don't know. So you have to be careful with who you take the advice from. I've been doing a lot of educating for speech and language pathologists. I'm actually doing a lecture Monday for some. So I think that they're kind of getting there with some of their training. But in some of the schools, they were taught like you never release a tongue. Like that was no, why would you do that? So to get them to understand the other side of it can be pretty tricky.
Well, I think the problem is because most people are always looking for the more conservative approach. And when you hear, you automatically think that's more invasive and that,
Yeah.
And I think people just need to be educated on it.
Well, and I will tell you, like with the pediatricians, I kind of get it, because if you see a child who had a tongue release done without function at the forefront of the provider's mind, it's not going to be very beneficial. If you do a tongue release without myofunctional therapy, if you do tongue release without looking at the full body, if you do it without educating the child on where to put their tongue, there's no real benefit there. And if you're just doing a quick snip, which is what a lot of people think a tongue release is, you're kind of missing the whole point. Like if you're not releasing to get that mid-tongue to elevate, which is typically one of the biggest problems, then you didn't really do much. So for a pediatrician to see those, and also to see them when they're overdone, when they're done poorly, they're trying to protect their patients. And I get that. But, not all providers are created equal. And so you need to find somebody who understands all of it.
Yeah, and that takes kind of my last thing. I know the number one question we're going to get is how in the hell do we find someone that's like you, Annie? And what are some of the questions that we should be asking our pediatric dentists that are specializing in tongue ties? And like what are some of the intro questions that know that you're in the right place? That would be one. And then number two, maybe if there are some dentists out there listening, like what would the education track look like to get up to speed on these types of things?
Yeah. So one of the main things to ask if you're looking for a tongue release provider is, what type of tongue release are you doing? Is it a functional tongue release? Is it functional frenuloplasty? Do you suture? There are some doctors who don't suture, and that's, I don't know, that's kind of provider preference. I personally think the wounds heal better when you suture. I don't suture babies, but the older kids I do. So you can ask, do you do a functional release? Do you suture? The most important of those questions is it a functional release? Do you work with a myofunctional therapist? Mm-hmm. Step one, do you work with a myofunctional therapist? If the answer is no, that is not the right provider for you. Mm-hmm. Because if they're not working with a myofunctional therapist, they're not addressing the function. And then in terms of finding providers, if you go to the Breathe Institute, which is Dr. Zaghi, he's an ENT who is kind of leading the way in a lot of this. I've done a lot of courses through him. I actually went and shadowed him. And he actually did my tongue release. So he is a great source of knowledge. He has tons of lectures on his own personal website, like lectures that he's given that
How
you
do you
can
spell
go
his
and
last
watch.
name for?
It's Zaghi.
Okay.
So his own personal website, which I think is just his name, he's got tons of educational material on there. But then the Breathe Institute, which is the institute he started, they have a map that you can look at and see providers who have taken their courses. Just because they've taken the course doesn't mean they, are super experienced or,
Can at least get the conversation started, though.
Yes, exactly. So there are affiliates who have done training, like they've gone and shadowed him and he's come to their office. So there's an affiliate, which is like the highest, and then there's ambassadors, which like I'm an ambassador because I've taken the courses and done these things. But, you have to take that with a grain of salt, but it's a good starting point. But also, I usually tell people, look for a myofunctional therapist in your area. Find that first, because the myofunctional therapist will know what providers to tell you to go to. They've seen the work of providers. They've done the networking, and that's part of what they help patients with, is finding people to help their patients.
And have you been able to bend like a Jeffrey Okeson's ear on everything that you're doing? Like some of these big names in dentistry and orthodontics, like are people listening to this journey you're on, or is it kind of a slow grow?
It depends. It's hard. This is hard to have it included in an ortho office. I'll be honest. It makes the whole process a lot more challenging because it requires a lot from the patients, the parents, everybody. It requires a lot more appliances and all those kinds of things. So it's kind of a hard sell. And for, orthodontists who are like, well, I've done this model this whole time, it's hard to switch away. Mm-hmm. So it depends. There's Dr. Olmos is a big name in orthodontics, and he has the TMJ sleep centers. This is a big thing for them. But outside of that, it really just depends. I would say it's a slow.
Yeah. Slow burn.
It's a slow burn.
Yeah.
Yeah.
Nice.
Anything to add, Bob?
Yeah. I would say if you're not on board yet, hop on board, because I really think
Bob's driving the bus.
Yeah, I mean, I really think the standards are going to come for this eventually.
Oh, I think you're right.
It's just we're just slow to adopt things here, right? And so if you don't know about this stuff, start educating yourself. And then find people to educate you, right? And so if you're not looking at it, look at it. So, eventually I firmly believe that the guidelines will be here for every profession for this stuff.
Would it be possible when we shut it down, like, could we do a quick little video assessment? I know we probably don't have the right lighting and stuff like that, but is it possible to like show our people something?
Yeah. I can do an assessment on one of you.
That'd be amazing.
I've seen and released it.
Yeah.
So,
I do have videos from previous classes that she taught for us too, as well. So that
you can include that in there. I will say one more thing.
Yeah.
If you are looking for an orthodontist and the orthodontist wants to take out teeth as adult teeth, if they want to take out adult teeth as part of the plan, that's not the place. Expand. Yeah. You want expansion. You don't want to make the space smaller. You want to make the space bigger. So
that's
what about
that's a pro tip.
Wisdom teeth are tough. We really should have enough room for our wisdom teeth if the jaws grew the way that they should. But wisdom teeth is kind of a different animal. I'm not totally opposed to getting wisdom teeth out, but I am opposed to having premolars taken out, which is the most common thing that many orthodontists still do. They still take out teeth. And so imagine what that just did for all your tongue space. You're pushing everything together, pushing everything back, making the airway smaller. So if you're trying to find an orthodontist and part of the plan is to take out healthy, permanent teeth, no.
Beautiful. What a good way to end. I think that's perfect. We covered a lot of great stuff. Annie, thank you so much for educating us, number one, and then for being willing to sit down. Bob, thanks for hooking us up, buddy. We were in Prague last year, and he couldn't stop talking about it, and so we knew that it was something special and definitely changing lives. So that's amazing. So with that being said, guys, we'll put all the show notes. Put all the stuff in the show notes, all your information as far as where to find you and things like that. But
nice tongue tie.
Yeah, tongue got your tongue.
He's on.
Anyway, we appreciate it, guys. Good luck with patience. We'll see you next time. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.